Okay, thank you. इधर है पूरा. कनेक्ट करना है इसको. Good morning, everyone. Good afternoon, rather. Please come up with your queries. Please come up with your queries. So the first query is question number 67. Question number 67 is, preterm labor is associated with all except. Let's take first question number 67. Preterm labor is associated with all except. So what are the risk factors which lead to preterm labor? Anyone? First question number 67. Right? The risk factors which cause, what are the risk factor, or what is the etiology of the preterm labor pain? The risk factors for the preterm labor pains are an over-distended uterus, infections, previous history of preterm labor pain. Okay, so over-distended uterus is found in the preterm polyhydramnios, asymptomatic bacteriuria and premature rupture of membrane are associated with infections, right? And fibrinogen in cervical discharge in first trimester. So fibrinogen is not found in first trimester. Fibrinogen is diagnostic of preterm labor pain if found within 24 weeks to 34 weeks. It is normal to have fibronectin in the first trimester. Is it okay? Now let's take question number 66. Absolute contraindication of copper T. 66 number question is absolute contraindication of copper T. So the mnemonic for it is India's top A, B, C, D. I stands for pelvic infections. These all are the contraindications. It can be PID. It can be PID. It can be puerperal sepsis. But it has to be pelvic infection. Current history. Current ongoing, not history. Current ongoing. Right? T stands for trophoblastic diseases. A stands for anomalies of uterus. B stands for undiagnosed vaginal bleeding. C stands for CA, uterus and cervix. A stands for ABC. D stands for diabetes mellitus with vasculopathy. Is it clear, Dr. Sumit? So, is unexplained vaginal bleeding is a contraindication. History of previous PID is not up. You are not going to take history of previous PID because almost PID occurs to each and every female once in life. So if PID is present recent, so these are the recent infections. Okay, recent. When you are inserting the PID, if there is inserting the copper T, if there is PID, then you will not put. History of previous PID is not to be entertained. Similarly, history of previous ectopic not to be entertained. You can see that here in the list there is no that previous of history ectopic, right? Last is HIV positive. In the HIV positive you can insert. Only these are the 5 contraindication of copper T. Okay. Next query was 62. This 62, let us see. This lady had polyhydramnios and we have to tell that what is true. Acute hydramnios is associated with always leads to labor prior to 28 weeks. It is not that the acute hydramnios will lead to labor before 28 weeks. It can lead to labor at any time. It can. Dr. Rahul is saying, ma'am, screen side karo. Okay, I'm doing it, Dr. Rahul. Is it okay, Dr. Rahul? So, the first was acute hydramnios was that there was in the acute hydramnios, it is not necessarily that the labor pain will be prior to 28 weeks. There will be preterm labor pain, but it is not necessary that the labor will be prior to 28 weeks. Is it clear? Is it clear? Next option is maternal edema, especially of the lower extremities, is rare. Beta, whenever there is polyhydramnios, due to the polyhydramnios, there is decreased venous return, right? Due to the over distended uterus. So rather the edema is on the dependent part and it is on the lower extremities and vulva, right? It is on the lower, so this is also false. Next is esophageal atresia is accompanied by polyhydramnios in 10% of cases. This is wrong. Whenever there is esophageal atresia, so almost in every case there is polyhydramnios, because the fetus cannot swallow the amniotic fluid, right? What is the source of amniotic fluid? The source of amniotic fluid is urine. And where does all this amniotic fluid goes? This amniotic fluid is swallowed by the fetus. So fetus is producing this amniotic fluid, and fetus is swallowing this amniotic fluid, right? So if there is esophageal atresia, so there will be polyhydramnios, not in 10%, almost in every case. The last one is right, beta. Complications of polyhydramnios include abruption, uterine dysfunction, and PPH. Because the uterus is over distended, so there is abruption occurs in PPH, polyhydramnios, PPH occur, and uterine dysfunction occur. Is it clear, Dr. Sumit? Please give a thumbs up if it is clear. Next is 56, 46, 58. Okay, first stage of the labor. We divide first stage of the labor into two phases, latent phase and active phase. Okay, the latent phase is up till 5 centimeter. From true labor pains up till 5 centimeter, and more than 5 centimeter to cervix fully dilated, that is 10 centimeter, is the active phase. So as given in the question, the patient was 4 centimeter, so it was latent phase. Is it clear, Dr. Sumit? 48. Following are the warning signs of development of Dr. Isra. It has been changed from the last 5 years. Okay, last 5 to 6 years it has been changed. Please correct in your textbook. That is why I always put this question. NEET PG in 22 already they have asked this question. It can be asked in your exams also. It is 5 centimeter. Please change in your books. Okay, now let us see 48 number question. Following are the warning signs of the development of diabetes in later half. Okay. One request is to you all students who are watching this, please like, share and subscribe my channel. Please, it supports me a lot. Okay, let's take 48 number question. Following are the warning signs of development of diabetes. See, it is saying that diabetes have developed in later half. Which is this diabetes? Diabetes mellitus in later half of pregnancy. It means that this is write down in the chat box. It means that it is gestational diabetes mellitus. When does gestational diabetes mellitus occur? At 24 to 28 weeks, right? As this diabetes has developed in the later half of pregnancy, so there will be no congenital anomalies, because organogenesis has gone. You all have studied now in gestational diabetes mellitus. In the gestational diabetes mellitus, yes, Dr. Raj, Dr. Isra, you are right. Yes, Dr. Rahul, you are right. In the gestational diabetes mellitus, there will be no anomalies in the fetus. Next time you are not going to do wrong, okay? Next time it should not be the query. Yes, Dr. Raj, you're right. Dr. Rahul, you're right. So there are no congenital anomalies in gestational diabetes mellitus. So answer is C, tendency to heart diseases. So what is the another name of gestational diabetes mellitus? The another name of gestational diabetes mellitus is diabetes in the later half of pregnancy. Questions come like this manner only. Okay? Okay? They just play words. Question number 46. Postmenopausal bleeding. What is the cause of postmenopausal bleeding? Write down in the chat box. Yes, Dr. Raj, organogenesis is done before 20 weeks. You are right. Postmenopausal bleeding. What is the most common cause? Most common cause. Dr. Sheffy, it is taken as latent phase. More than 5 centimeter is active phase. Dr. Sheffy is asking about this question. If cervix is 5 centimeter, then this is latent phase. Okay. Okay. And if it is more than 5 centimeter, it is active phase. Question number 46. Most common cause of postmenopausal bleeding. No, I am not getting the answer. Correct answer. Please tell me what is the most common cause of postmenopausal bleeding. This is the expected question. No. Postmenopausal bleeding, Dr. Rahul, not postpartum bleeding. Postmenopausal bleeding. What is the most common cause? No, I'm not getting the correct answer. Please write down the correct answer. The most common cause of postmenopausal bleeding. Dr. Sumit, Dr. Ayushi, Dr. Rustler, Dr. Divya, Dr. Rahul, Dr. Ekta, please write down the most common cause of postmenopausal bleeding. No, it is not endometrial atrophy. Please don't write endometrial atrophy. Yes, Dr. Sumit, it is right. Most common cause of postmenopausal bleeding and of postcoital bleeding, both is CA cervix. Is it okay? Is it okay? Next time you are not going to know, Dr. Ekta, it is not endometrial carcinoma. Okay. And what is the most common cause of postmenopausal bleeding in word? No, Dr. Raj, it is not endometriosis. It is CA cervix. Okay, CA cervix is much common. Please don't do this mistake. Dr. Isra, you are giving here Indian exams. So you will write here as per India most common thing. Okay. Even if it is not written in India, you have to write it in India. If it is written most common cause of postmenopausal bleeding in word, then you have to write endometrial atrophy. Okay. 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 Next question is, what you do? What is your first step if a patient comes to you with postmenopausal bleeding? Patient came to you with postmenopausal bleeding. What is your first step? Come up. What is your first step? If a patient comes to you with postmenopausal bleeding, The first step is to rule out the most common cause, that is CA cervix, either by no Dr. Isra, no Dr. Rahul, as we studied that most common cause of postmenopausal bleeding is CA cervix, so you will rule out CA cervix. So you will do colposcopy biopsy. Okay, and the next, because in the option colposcopy biopsy was not there, so we will do the endometrial biopsy. Okay, we will rule out the second most common cause, right? So in the option there was, so now we will do endometrial biopsy. This is how the question came these days, no controversy. Okay, 4-5 years back both were there, colposcopy biopsy and endometrial biopsy, both were written in the options, but these days no controversy, only endometrial biopsy options are there in the exam. Which endometrial biopsy is best? Which endometrial biopsy is best? Hysteroscopic guided biopsy. Hysteroscopic guided biopsy. Okay, is it clear? Dr. Rachna, I am coming. Let me take it serial wise. 12. Question number 12. In question number 12, there is cord prolapse. Cord prolapse with cervix fully dilated. Station at +3. Dr. Yushi, it was your query. Okay, it was, yes, it was a cord prolapse with station at +3, right? So because there is cord prolapse, the fetal distress will occur very soon, so we have to do the delivery. If the cervix is fully dilated then and station is more than +2, then we are not going to do the cesarean. Okay, because we can extract the baby by forceps or vacuum. But here next thing it was written non-rotated vertex. Non-rotated vertex. So in the non-rotated vertex you have to rotate the vertex, so the choice becomes vacuum. Is it clear? Is it clear, Dr. Ayushi? (27) Dr. Rachna, your questions are 27, 33 and 37. You are examining a multigravida in the second stage of the labor for the past 2 hours. Okay, so for 2 hours you are observing. This is question number 27. Okay, and the contractions were adequate. Contractions are adequate. Okay, and next is that cervix is fully dilated. The patient is in second stage. Cervix is 10 centimeter. Station is 0. And there is moulding and caput, both are there. and the sagittal suture is in the right occipito-transverse arrest. Okay, so sagittal suture is in transverse. What is the diagnosis? Okay, Dr. Rahul, we will discuss. What is the diagnosis? From the 2-hour, this is the condition. Plus there is molding and caput. Can you tell me what is the... Yes, Dr. Isra, the diagnosis is deep transverse arrest. Okay, the diagnosis is deep transverse arrest. So, what is the management of deep transverse arrest? What is the management of deep transverse arrest? We can apply forceps or vacuum. No, Dr. Rahul, it is not only cesarean. In this case, it is cesarean. If the station is at +2, then we can apply forceps and vacuum. But as the station was +0, so okay, as the station was 0, so the only option which we are left with is LSCS. Have you got it? Yes, Dr. Raj, you are right. Dr. Iman Abdullah, please take a note. If in this question they have given station +2, we would have chosen forceps or vacuum. Okay, in the deep transverse arrest, the treatment depends on the station. Okay, is it okay? Dr. Rachna, is the query clear? After that is 33 and 37. Thirty-three was an easy one. What is the... This is a case of ruptured ectopic. Right? In the ruptured ectopic, what is the treatment? In the ruptured ectopic, the tube has teared. So we will do salpingectomy. No other treatment. Why we will do salpingostomy, beta? Because we will do salpingectomy because already the tube is teared. Already the tube is teared, has ruptured. Okay, we will do salpingectomy because in the question it was written vital stable. Vital stable. If the vitals are stable, then we have to do laparoscopic. Okay. Is it clear? If the vitals are unstable, please write down in the chat box why in the stable vitals we do laparoscopy. Why don't we do laparotomy? Why in the vitals unstable we do laparotomy? Why we don't do? Yes, Dr. Sumit, we do salpingostomy in unruptured case. Okay. Write down in the chat box that why we don't do laparoscopy in unstable patient. Now, if the ectopic is unruptured, then there are two managements: medical management and please write down in the chat box why don't we do laparoscopy in unstable patient. Write down on this thing. Many times they ask you question. Salpingostomy. Medical management is done if the gestational sac is less than 4 mm and beta HCG is less than 3000 to 5000 and FHS is absent. Otherwise we do. Dr. Raj, that is what I am telling, that in unruptured there are two managements: medical management and salpingostomy. Okay, it is better. It is better to do medical management if these criteria are met. Okay, if these criteria are not met, then one has to do salpingostomy. And if it is a ruptured ectopic, then only salpingectomy. If vital stable, then laparoscopic. Now please listen carefully. Why in unstable vitals we don't do laparoscopy? Because when the vitals are unstable, we have to give, because for laparoscopy we have, which anesthesia we have to give? Anesthesia given is GA, general anesthesia. Is it clear? Is it clear? So GA is not given in unstable patient. Okay, Dr. Isra, rather spinal causes hypotension, but that can be managed. If we give GA to unstable patient, then the patient will get ventilated. Okay, so rather than keeping the patient on ventilator, is it clear to everybody? Because for the laparoscopy, anesthesia required is GA, and GA is not given in unstable patient. Okay. After 33, it is 37. Investigation of choice in endometriosis. Dr. Rachna. Investigation of choice in endometriosis. Beta, in endometriosis, what we have to see? We have to see adhesions, right? We have to see distorted anatomy. that can only be seen on laparoscopy. Tell me one gynae condition. Beta, because in why not general anesthesia in unstable patient? Because when we will give the general anesthesia to an unstable patient, then the patient has to be kept on ventilator for 2-3 days. Okay. So to avoid all that 2-3 days complication, we do the open procedures. Right? Because in general anesthesia, we stop respiration, we stop many things, right? So unstable patient with very difficulty comes out. It takes 2 to 3 days for the patient to come out, and we have to keep the patient on ventilator. So to avoid that complication. So tell me one gynae condition in which again laparoscopy is the best investigation. One condition is endometriosis. What is the another condition? The another condition is PID. Okay. These are the two conditions in which laparoscopy is the best. Write down in the chat box, when is the MRI best? (43) and 39. Let us take 39. What is 39? In 39 is target fasting 1 hour, 2 hour levels in gestational diabetes mellitus. See, one values are to diagnose diabetes mellitus. To diagnose diabetes mellitus, the values after doing 75 gram glucose tolerance test. What are those values? 92, 180, 153. But once the patient has been diagnosed diabetes mellitus and put on yes, Dr. Isra, you are right, adenomyosis and placenta previa plus placenta accreta. So MRI is the investigation of choice for adenomyosis previa and accreta. Okay. Accreta was asked in the last year PYQ. So to diagnose the diabetes mellitus, we perform 75 gram glucose tolerance test. Here the word is target. Once the patient has been diagnosed, we have pushed the patient on insulin. Now what should be our target? That is the treatment. We have diagnosed the patient as gestational diabetes mellitus. Now in the target, what are our target when the patient is on insulin? So that we will not increase insulin after that. The targets are 90 fasting, 140 in the first hour and 120 in the second hour. Is it clear, Dr. Sumit? 43. Next query is 43. Here you were doing what is the maneuver being done? What is the maneuver being done? In 43 number question, what is the maneuver being done? The maneuver which is being done is controlled cord traction, Brandett Andrews method. right? Okay, now during that maneuver the cord teared, okay, and there was incomplete separation of placenta. So this is a case of retained placenta. And what is the management of retained placenta? Yes, what is the management of retained placenta? Yes, you're right, Dr. Isra. What is the management of retained placenta? Oxytocin plus manual removal of placenta, MRP. Okay, let's take the another query. (51) and 62. 51 is absolute contraindication of COCPs. What are the absolute contraindication? Dr. Rahul have asked, what are the absolute contraindication of COCPs? I always tell you that the estrogen, it increase the coagulation factor, right? Estrogen increases the coagulation factors, beta. So it is not to be given in the patient whose endothelial is damaged. That is what the Virchow triad tells. Endothelium is damaged in hypertension more than 160 by 110, diabetes mellitus with vasculopathy, migraine with aura, right? Smoker, age 35 plus more than 15 cigarettes per day, right? It is not to be given in which the blood is stasis, blood flow is under stasis. It is in heart diseases and brain diseases. It is not to be given already in which there is increase in the coagulation factor, the thrombophilia diseases and postpartum. It is not to be given in lactation for the first 6 months. It is not to be given in the liver acute diseases because it metabolizes. Okay, have you got it? So STD is nowhere written. And 62 is? 62 has been already discussed. Dr. Gurdeep is asking, Dr. Gurdeep is, Dr. Isra, what about the insulin dose? Once the target is achieved, we will stop the increments. Dr. Gurdeep Aluwalia is asking, let me take small questions. Oceans, which ligament makes anteversion? Anteversion is due to uterosacral, and anteflexion is due to round ligament. Okay, is it clear, Dr. Aluwalia? Dr. Gurdeep Aluwalia, is it clear? Anteversion is due to, see what is anteversion? If this is vaginal axis, this is cervix, and this is uterine axis. The angle between the vagina and cervix. This is vagina, this is cervical axis, and this is uterus axis. The angle between the vagina and cervix is called, please tell me. Anteversion. V for vagina, V for version. Angle between the cervix and uterus is called flexion angle. What is the flexion angle? 120 degree. What is the version angle? 90 degree. So this pull is done by the uterosacral. Here somewhat the uterosacral is there. ऐसे पीछे खींच रहा है यूट्रोसेक्रल, ठीक है. और ये यूट्रस, वाई राउंड लिगामेंट इज मेकिंग द यूट्रस फ्लेक्स? बिकॉज राउंड लिगामेंट, this is uterus, this is round ligament. So round ligament starts from the fundus, then it goes into the lateral pelvic wall, and then it goes into the inguinal canal and get insert at the anterior end of the labia majora. Here it insert in the anterior end of labia majora. Okay, so because this round ligament is going in front and downwards, that is why the round ligament is flexing the uterus. ओके, कोई भी चीज किसी को आगे और नीचे खींचेगी तो वो मुड़ जाएगी ना. इफ एनी लिगामेंट इज पुलिंग द यूट्रस इन फ्रंट एंड डाउनवर्ड्स, देन इट विल गेट फ्लेक्स, राइट? I hope you have got, Dr. Gurdeep. Ma'am, can you explain all condition when we use laparoscopy and hysteroscopy? Dr. Rachna, laparoscopy is used to see the peritoneal cavity conditions. Okay, when we have to see the endometriosis, when we have to see the PID, there we have to see in the peritoneal cavity adhesions. Okay, now you tell me, Dr. Rachna, if there is a subserous fibroid, how will you remove it? By laparoscopy or hysteroscopy? Tell me, how will you remove the subserous fibroid? Bacha, tell me. Subserous fibroid, because they are in the peritoneal cavity, is removed by laparoscopy. Okay, yes. And if there is submucosal fibroid, Dr. Rachna, it is not hysteroscopy. Subserous, serosa is in the peritoneum. Okay, the submucosal is in the uterus cavity, endometrial cavity. Beta, there we will do the hysteroscopic removal. Is it clear? Dr. Rachna, is it clear? Is it clear? Where we will use? Okay, submucosal is in the endometrial cavity. So if we have to see anything in the endometrium here, right, then we will do the hysteroscopy. Okay, if we have to see anything here in the peritoneum cavity outside the uterus, then we will do laparoscopy. Tell me one question. Uterus surface uterus surface is seen on hysteroscopy or laparoscopy? Write down. Till then I will take the next query. Dr. Isra is asking when to choose forceps and when to choose vacuum in DTA. Depends on the rotation. We can choose any. If there is fetal distress, then we will use forceps. If there is no fetal distress, then we will use vacuum in deep transverse arrest. Okay, but these both will be applied at +2 station. Okay. Dr. Rahul, if the station is minus, then we have to do LSCS. If station is less than +2 or minus, we have to do LSCS. Dr. Rahul, you have asked about beta HCG. One question on beta HCG is definitely in your exam. Okay. Dr. Rachna, yes, Dr. Rachna, you are right. For uterine surface laparoscopy, we have to use. Yes. One question on beta HCG is definitely going to come. What is the chemical nature of beta HCG? What is the chemical nature of the beta HCG? Glycoprotein. And from where the beta HCG is produced? Syncytiotrophoblasts. Rather, all the hormones are produced by syncytiotrophoblasts. Beta HCG doubles in 48 hours in intrauterine pregnancy. Right? It peaks at can anybody help me? It peaks at beta HCG has 2 subunit, alpha subunit and beta subunit. Yes, Dr. Shafi, you are right. Beta HCG peaks at 10 weeks. Okay. And beta HCG has 2 subunits, alpha subunit and beta subunit. Alpha subunit is similar to LH, FSH and TSH. But beta subunit is also similar to LH. So, HCG is luteotropic, that it does many jobs of LH. Number 1, it maintains corpus luteum. Yes, you are right, Dr. Iman. It maintains corpus luteum. If the lady gets conceived, right, It stimulates because it acts like LH. It stimulates testosterone production in male fetus in early pregnancy, because at that time there is no LH, only HCG is there. And third, its luteotropic action is in molar pregnancy, where there is lot of HCG, it forms theca lutein cyst. Is it clear? Dr. Rahul, is it clear? When to choose endometriosis? Beta, in endometriosis happens in third decade at 25 to 35 years. It happens in nulliparous, right? And what are the findings in endometriosis? What are the findings in endometriosis? There are peritoneal adhesions. There are peritoneal adhesions. Right? लाइव क्लास चल रही थी.
ओके जी.
Peritoneal adhesions are there. Peritoneum adhesions. Right? There is distortion of anatomy due to the ectopic sites of endometrium. Right? So there is dyspareunia, dysmenorrhea, infertility. Is it clear, Dr. Rachna? Whereas in adenomyosis, the endometrial gland is in myometrium. So uterus enlarges. It is a uniform enlargement. Whereas uterus does not enlarge in adenomyosis. Dr. Rachna, clear? And adenomyosis happens in multiparous ladies. Okay, is it clear? Dr. Rahul has asked 51 and 62. 62 has been discussed. 51 has also been discussed. Then Dr. Sumit has asked question number 15. Expected management includes all except. Question number 15. Expectant management. If there is warning, hemorrhage, in placenta previa. Warning hemorrhages are those hemorrhages which stops themselves. Okay, but for that we have to observe. Yeah, Dr. Rachna, it is right. For the uterine surface, we have to do laparoscopy. Okay, so now let us see this question number 15. So in the 15, you know that for in the placenta previa, the warning hemorrhages happen and they stop spontaneously. But you have to observe to see whether this hemorrhage is spontaneous or not. So how you will, what all treatment you will give. So you will give betamethasone for the lung maturity. You will give sedation. You will give anti-D if the mother is Rh negative, right? But we will not do cervical encirclage, right? And we will also get the blood transfusion or blood arrangement because the lady is having placenta previa. Might be we have to do cesarean. Okay, is it clear, Dr. Sumit? Next is warning hemorrhage occur in other cases rather than placenta previa, ma'am. I don't get your question, Dr. Isra. Please write. Warning hemorrhage kab occur, kab occur. Please write down clearly, Dr. Isra. Dr. Isra has asked 56 and 59. '56 we have done. 59. Vaginal delivery is done in all of the following. When the twins are monoamniotic. Beta, we don't do vaginal delivery. Okay? In the twins. No, beta. Warning hemorrhage is a term exclusively for placenta previa. The bleeding in the placenta previa which stops spontaneously is warning hemorrhage. That's all. No, it is not in ectopic pregnancy. Monoamniotic twins, we cannot do normal delivery. We have to do cesarean, right? And we can do cesarean in diamniotic, dichorionic, twin if the first baby, which is the first baby, the baby which is down, first baby, the one baby which is in the lower part. Okay, the baby which is in the lower part is the first baby. If first baby is vertex, then only we can do the normal delivery, right? Dr. Ekta has asked question number 8. Dr. Ekta, Question number 7. Oh, sorry, 8. Here in the partograph, you can see that there is no progress of labor since last 2 hours, right? There is no progress of labor there is no progress of labor in last 2 hours. Can you see? PV finding is same. PV finding is same. PV finding is same. There is no progress from the last 2 hours. Okay. So this is the case of CPD. If in spite of presence of good contractions, if no progress is there, it means that it is CPD. Okay. It is not a normal labor. Let's see other. It is not a primary dysfunctional labor. No. Okay. In normal labor, there is no descent also. Yes, Dr. Isra, you are right. Dr. Sumit, in question number 7, the another name of candidal vaginitis is monilial vaginitis. Monilial vaginitis. Is it clear? In candida vaginitis, there is curdy discharge. Okay. Is it clear, Dr. Sumit? Next is 46 we have taken. 48 we have done. Next query is 40. 40 is an important question. What is mifepristone? What is the another name of mifepristone? Please write down in the chat box. What is the another name of mifepristone? RU 486. Mifepristone is anti-progesterone, right? So where it is used? It is used for abortion, induction, labor pain induction. It is used in fibroid and it is used in, yes, it is used in fibroid and endometriosis. Plus it is used in meningioma and ectopic pregnancy. These last two are rare uses, but it is used. In the ectopic, it is used to kill the fetus. Dr. Isra has asked question number 42. They were asked monochorionic twins develop. See if the division of the embryo occurs from 0 to 4 day. after fertilization, right? Then the twins which are formed are diamniotic, dichorionic. If the embryo division occurs more than at 4 to 8 days, then it is formed monochorionic diamniotic, because the trophoblast has been formed. Once the trophoblast has been formed, it will not divide again. Okay, then only the other part other than trophoblast they divide, right? Because after 4 to 8 days there is structure is like this. This is embryonal cell mass. So when division occurs at 4 to 8 day, then the trophoblasts do not divide. So these two embryonic cell mass are left, right? And if the division occurs at 8 to 12 days, then amniotic sac is formed. So amniotic sac will also not divide. So it will form monochorionic, monoamniotic. So is it okay? Yes, Dr. Isra, we can do NVD in monochorionic diamniotic. I have to check. I think we cannot do. I will check and tell you. Okay? I think we cannot do in monochorionic diamniotic. I will check and tell you. If the division occurs more than 12 days, then conjoined twins. Question number 8 has been taken. Now question number 48. Question number 48 is taken. Question number 9. If it is a complete prolapse, then we have to do vaginal hysterectomy. If it is a prolapse, then the procedure is vaginal hysterectomy with pelvic floor repair. Unless and until anesthetists give us a condition that it cannot be done due to any morbid condition, right? So after 9 it is (48) was taken, 9 is taken. Then next it is 8, 12, 27. Eight has been taken, 12 has been done, 27. 27 has also been done. Twenty-four. Polymenorrhea. What is polymenorrhea? Polymenorrhea means that the cycle length is small, so they will occur frequently. So frequent cycle Dr. Sheffy, Dr. Sheffy, indication for Lee forte is if there are if anesthesia cannot be given for 1 hour. Lee forte takes only 5 minutes. Okay, so if there is moderate risk of anesthesia, Dr. Isra, because forceps cannot be applied in non-rotated vertex. Okay, if it is a non-rotated vertex, then we have to choose who's it. Then we have to choose vacuum. Forceps cannot rotate. Question number 24 is done. Polymenorrhea. In the polymenorrhea, the cycle length is small, less than 21 days. So periods come quite often, right? Frequent cycles. But bleeding is of course normal. If bleeding is more, then we say that it is, if bleeding is normal, yes, Dr. Isra, it is E. coli. Okay. If bleeding is high, then we say it menorrhagia. Okay. I think all the queries have been done. Please write down in the chat box if any queries left. Dr. Isra, forceps can be used for rotating 90 degree, but not more than that. Forceps can be used for rotating 90 degree, but more than, yes, Dr. Sumit, please tell what you want, but not more than that. Can you explain mento-posterior and mento-posterior? Yeah, Dr. Sheffy, in face presentation, there are two positions, right? Mento anterior, The denominator is mentus, chin. Mentum is the denominator in face presentation. Okay, I'm telling you, Dr. Sumit, mento anterior and mento posterior. Right? In mento anterior, normal delivery is possible, whereas in mento posterior, normal delivery is not possible. That's it. That is you have to do. Dr. Chef, is it clear? All the hormonal tests, all the hormonal tests are done at day 3. Okay, except AMH, TSH, prolactin. Yes, Dr. Sumit, please speak out. Evening class के session में what you want to say? This AMH, TSH and prolactin can be done at any time. Progesterone is done at day 23 for ovulation. Okay. Evening session, you want it now? Actually, my patients are waiting. We cannot do it now. Okay, if you want, then I will try tomorrow. For the tomorrow class, I can try. Any other query left regarding the quiz, please tell. Okay. Thank you. Thanks a lot. We are closing the session here.